So can we expect that in the future, the drugs that we've been talking about, the incretins, are going to be part of standard diabetes treatment?
Yes, absolutely. I mean, they're already well established into our pathways. NICE has approved many GLP-1s up to this point. Tirzepatide has just got its final approval through NICE now. So we're moving to that being released probably in the next few weeks to months here. So we're excited about that. So I think absolutely it's got its place in therapy. We need drugs like this. The main attraction, I suppose, so far with the GLP-1s that are already on the market is they've got good outcome data. So there's data around not just the weight loss and the HbA1c lowering, but specifically around protection for cardiovascular events. And so we know people with type 2 diabetes, well, people with diabetes in general, but in this case, we're talking about type 2 diabetes. People with type 2 diabetes have a very high cardiovascular risk. Some of them have already had cardiovascular events, and we need to protect them from having further events or from having their first event in the first place. And these drugs are very efficacious for doing that. So they've got good outcome data to show that you're less likely to go on and have a further event, and that you're less likely, if you have an event, to die from that event. You're less likely to be hospitalized, etc. And then the other part of things is around stroke prevention as well. So the GLP-1s actually have good stroke data. Which is slightly deviates from some of the SGLT2 work that's been done. Obviously, SGLT2s have good data also around cardiovascular events, particularly heart failure, but they don't have the stroke data. So the GLP-1s kind of come into their own around stroke, so which is interesting. So the tirzepatide and the retatrutide, we're waiting on some of the outcome data for that still, but obviously we can you don't want to leap to conclusions, but I'll eat my hat if they're not got good outcome data, to be honest.
Now, all the agents that we've talked about so far are peptides, and they have to be injected. But recently I've read about orforglipron, which is an oral non-peptide GLP-1 agonist. What impact could this have?
Yeah, I mean, people do. We've already seen it. So we've got an oral GLP-1 on the market, albeit that we can't get hold of these GLP-1s at the moment. But Rybelsus. So it was really nice to have an oral option. There are people who are needle phobic, or they really are very resistant to starting an injectable therapy. So with the oral agent, it gives you this option where you can give something. The problem with the Rybelsus is that it is a peptide. What the company has done, Novo Nordisk, is that they've wrapped the peptide in something called a snack protein. It's really, I mean, to be honest, I do find these things absolutely fascinating. But they basically wrapped this little coating, I suppose, if you like, this protein around it, so the protein gets degraded and the peptide stays alive and manages to get to where it goes. So that's how they've manufactured theirs. But because of that, you have some significant sort of administration instructions that if they don't follow the if the person living with diabetes doesn't follow those administration instructions, you've then got problems with that being absorbed in the way that we would want it to, and it actually being efficacious. So you have to take it well away from any other food, medicine. You can only take a sip of water, not too much water, otherwise it passes too quickly and the snack protein stays intact and doesn't release the peptide. So you do have to follow these admin instructions, and it does make me wonder whether people are really going to be that adherent with those instructions, and whether we will get this kind of bouncing around of the blood glucose because people sometimes do and sometimes don't follow, or they maybe follow some of it and not all of it. So it does make me wonder what happens. So the new one just means that it's not a peptide. It's not got, you don't have to go to these great lengths. It does stimulate the GLP-1 receptor, but it's not a GLP-1, so it's not a peptide. So it's very clever, and I think that we've got a whole cohort of people who really would rather not be on an injectable therapy. For them, that's got significant concerns. Some of them have relatives who have been on insulin, had very traumatic experiences around insulin admin, particularly if it's been a parent or a grandparent where they've been on like 8mm like massive needles with their insulin, and they've been really traumatized by seeing insulin in historically. So you can buy some time for them, I suppose, in the sense that this will give us something which is efficacious without needing to go onto insulin or needing to go onto injectable GLP-1. It's almost like another step for me.
Mm-hmm. And what would you like frontline practitioners, I mean, pharmacists, nurses, doctors, and so forth, what would you like them to be telling patients about these drugs?
I think it's really highlighting the sort of breadth of their benefits to people. You know, we know that there's lots of clinical inertia in practice. There's lots of giving people lots of time riding with quite high HbA1cs often and weight gain. And I think I would like people to really consider not giving people years between, you know, if somebody's got a really high HbA1c, you know, that we shouldn't be leaving that for a year to then revisit with something. I appreciate that it's all about the holistic management of somebody, and we do need to put in lifestyle and dietary advice. But there are circumstances where if somebody's very high or very high cardiovascular risk with a high HbA1c, we do need to action something relatively quickly. Time is heart, it's kidney, it's eyes, it's all of these things. And you know, when you're not doing something, damage is happening. And I think that's something that I would really like practitioners to think more about, and to try and highlight that really to people. It's all about person choice. Some people still won't want to pursue something. They want that time to intervene with diet and lifestyle. Some people do well. We've got the remission program now at our disposal, which is if you're within 5 years of diagnosis, we can refer people to remission. So there are some more efficacious, more intensive lifestyle options as well that would be certainly something that I would pursue for my younger people living with type 2, most certainly, and in that very short window from diagnosis. But I think for many, they'll lie outside of that, and we still need to be doing something and highlighting certainly the cardiovascular benefits and the protection to your kidneys. If they've got albuminuria by then, you know, time is kidney at that point. If you've got overt albuminuria, you need to be doing as much as you possibly can to protect those kidneys relatively quickly.